So I invite Dr. Rajvardhan, consultant at our hospital, Sarjapur, Bangalore, who's kindly agreed to do the ABG session for us. And like we discussed earlier, ventilator graphics most likely will be an independent station. ABGs probably could be incorporated into the clinical stations. So as much as possible, please be mindful of reading ABGs even in between the clinical stations. So be crisp rather than starting to read it. So I'm sure Dr. Rajvardhan will go through it. And following the ABG, Dr. Carol D'Souza from St. John's Medical College will take us through the basic graphics and how to read it and probably how to approach it for the exam. So I thank both of the presenters, and I'll let Rajvardhan start off with the ABG session. Thank you.
Thanks, Dr. Rajvardhan. Thanks, Jason, for allowing us to be part of this. Okay, it's been a pleasure. I see you every day logging in, doing all these things. It's a difficult task, per se, to coordinate all this stuff, and you're doing a wonderful job. Thank you for that. Today we are going to discuss about ABG. So you should understand that I'm not here to teach you people. Okay, it's from the exam perspective. It's only how you approach an ABG when they give it to you in the exams. It's all that we are talking today. No theoretical discussions. Okay. So here I'm giving a scenario. We have any volunteers? Any of you?
Hello, sir. Good evening, sir. I'm Dr. Pradeep.
Good evening, Pradeep. I will discuss the scenario now. Okay, 34-year-old man presents to emergency and is worked up. They're told it's a possible metabolic encephalopathy. His blood gases are as follows. His pH is 7.31, PCO2 of 26, PO2 of 94, sodium of 138, potassium of 4, chloride of 103, and bicarb of 108. How will you approach an ABG if they give you an ABG? First thing.
So mainly, first I'll validate the ABG, sir.
Yes, good.
So, mainly based upon Henderson-Hasselbalch equation. Okay. So H plus equal to 24 into PaCO2 by HCO3, sir. It's the acid by base.
Yes.
Yes, sir.
Can you tell me whether this ABG is validated or not?
Yes, sir.
You should take a pen and paper. Any of you are there? Please.
Yes, sir. I'm doing so.
Others also, please try to solve it when he's solving also. If you're able to get the answers before, you can tell.
Looks like a valid ABG.
Valid ABG. I think you've done some mistake. Okay. So
yes,
whenever they give a pH, first thing is you should calculate what is the H plus approximate H plus concentration. There's a tabular column which is given in most of the books. Okay. Other thing you can easier to remember is you can take 7.40, you start with 40. If 7.40, it is 40. Okay. For 7.30, it's 50.
Okay.
For 7.2, it's 60. From then onwards, initially, first two, it will decrease 10-10. Then onwards, it will decrease by 20-20, like 80-100. This is one of the simpler way to remember. Example, when you're doing a validation, by using this formula, you can validate. In this, for PS 7.3, the value should have been 50. Here, we are getting 34.7. So this ABG is not validated. So whenever the first thing an examiner asks, how do you approach this ABG? First thing you should do is validate the ABG. If they say no need of validation, you can go ahead, you can go to the next step. Okay. I'll give one more scenario. This any ABG interpretation, there are specific steps are there. One is validation. Oxygenation status, you will do it if they're given the scenario, if they're given a PaO2, if they're mentioned already, and if they're given a FiO2, how much is a FiO2 or on room as they mentioned, you can check the oxygenation status. Next is by looking at the pH, determining whether it's acidosis or alkalosis, whether it's a metabolic or respiratory, then compensation, then anion gap and delta ratio. Okay, we'll go through the steps in one of in some of the questions now. Okay, this is the first example. A 40-year-old male alcoholic is admitted to emergency department with GCs of 3/15, heart rate of 110, BP of 90/60, respiratory rate is 35. His pupils is bilaterally absent direct reflex is there. Pupils are dilated. Okay, this is a ABG along with some other labs have been given. pH of 7.12, bicarb of 15, PCO of 28, PO of 96. Electrolyte sodium is 140, chloride is 100, potassium of 5.2. They again measure osmolarity and calculated osmolarity. How will you approach this, Dr. Pradeep? You take that validate exam ABG is validated. Go forward with the next.
Yes. Yes, sir. This ABG is validated ABG. So next I'll go ahead with primary problems, sir. Based upon the pH, so it shows acidemia, sir.
Yes, good.
Because pH is less than 7.3. So it is acidemia. Then based upon bicarb and PaCO2, it's metabolic acidosis. So
Okay.
primary problem is metabolic acidosis.
Good.
And then compensation. So it is compensated metabolic acidosis.
What is the formula you use for compensation for metabolic acidosis?
It's a winter formula 1.5 into PaCO3 plus 2 plus or minus 1. Based upon winter's
1.5
formula into PaCO2.
Yes.
Plus 8 plus or minus 1.
Yes, correct.
So based upon winter's formula,
1 minute.
I'll calculate expected PaCO2.
Pradeep?
Sir?
1.5 times into?
Sir?
1.5 times into?
Bicarb, sir.
Bicarb.
1.5 times into bicarb.
Yes.
Plus 8 plus or minus 2.
Okay. So that is compensated?
So I got around 32. Yes, sir, it's a compensated.
Yes. Next, you got a primary metabolic acidosis with compensation. Then next, what will you do?
Primary metabolic acidosis with a compensated respiratory alkalosis.
Okay.
I'll calculate anion gap.
Okay. How much is the anion gap in this patient? You remember the numbers?
$25 or something. Okay. 30. Yeah.
I think you'll have to go back, Rajvardhan.
Okay, fine.
At least tell us the formula, Dr. Pradeep, for the anion gap.
Okay.
$25. Yeah.
Anybody else? What is the anion gap? Please participate.
Sir, it's a high anion gap metabolic acidosis.
Okay.
So 25, sir, anion gap.
Okay, fine. Okay. Next, what will you do once you got an anion gap?
I'll calculate the delta ratio, sir.
Yes, please. Okay.
So delta ratio, it's
Please, others can also volunteer. Dr. Ramya, you are quite good. Please answer in the group. It will be more useful if others also can hear from you how to approach. You got a very good diagnosis. I really appreciate it. You can, if you tell and tell others also, no, they can also learn it. Yeah, please go ahead.
So the anion gap is 25 here.
Yes.
So the delta anion gap is around 13.
Hmm.
So and the bicarb was so the delta bicarb is coming around 90, sir.
Yes.
So the delta ratio is more than 1. So there's a associated metabolic alkalosis with the HACMA. And since there's an osmolar gap more than 10 between the measured and calculated, so probably it could be even methanol poisoning because it's known alcoholic.
It's perfect. Okay. In the exam, you'll get this kind of scenarios, quite common. Make sure that you don't waste much time in the exam. Okay. You should be at the this is how we are thing here. Okay, then one of the NEGM journal, they have given a very nice approach how to approach any patient of metabolic acidosis, how to calculate anion gap, how to approach if there's anion gap is positive and all. Okay, please go through that NEGM article. I'll share it in the group. Okay. Next scenario, a 16-year-old female presents with weakness of 1 month duration, BP of 105/68, heart rate of 98, respiratory rate of 22, temperature of 99 degree. She couldn't move any of her extremities, saturation 86%, symmetric reflexes, normal sensation. Her KUB showed multiple calcification. So this is the ABG of that patient. pH of 7.35, PCO2 of 30, bicarb 16, PO2 of 87, sodium 138, potassium 1.8, chloride of 114. Urine electrolytes also has been given for this patient. Sodium of 28, potassium of 3.4, and chloride of 60. Potassium of 34, sorry. Anybody else? Please go ahead.
Hello, sir.
This
Sir,
test
actually,
has been
based upon
validated.
this, yes, it's validated.
Okay, go ahead.
And primary is like acidemia, sir. It's 7.35. Primary is, it looks like metabolic acidosis, sir. Primary metabolic acidosis.
Good.
And compensated respiratory alkalosis.
Okay.
Yes.
Next.
1 minute. And it's a normal anion gap metabolic acidosis.
Good. Good. Perfect. It's a normal anion gap metabolic acidosis.
Normal
okay,
anion gap metabolic acidosis.
How will you approach normal anion gap metabolic acidosis?
So based upon urine anion gap, sir. Mainly. So urine anion gap. So it's more than 6. It is positive, sir. Urine anion gap is positive.
Okay. So it's a renal tubular acidosis.
So it is it's a renal tubular acidosis, sir.
Given the background scenario of hypokalemia and normal renal tubular acidosis with low potassium, patient having hypokalemic periodic paralysis, most likely it's a renal tubular type 1 renal tubular acidosis. Okay. The first scenario I mentioned,
Yes,
in the exam also same scenario is there. Okay. In the context of DKA, please make sure that you understand how to approach it. It will come invariably in the exams. At least 1 out of 5 people will get that scenario. Okay. This I will approach. Third question. 26-year-old female presents with vomiting and loose stools. Patient is noted to have fatigue and weakness. BP of 110/70. Heart rate of 80 beats per minute. Respiratory rate of 12. This is a lab picture. Shows sodium of 136. Potassium 2.8. Chloride of 90. Bicarb 36. Potassium pH of 7.5. PCO2 of 46 and urine chloride 1. Okay. How will you approach this patient?
So is validating the ABG. So
Yes, take it for granted. It's valid.
After that, the primary problem is pH 7.5, sir. It's alkalemia.
Yes.
And the primary problem is metabolic alkalosis.
Yes. Okay. Next, what will you do?
Yes, calculating the expected PaCO2, sir. Expected PaCO2. So
What
the
is the
formula is
formula?
0.7 into PaCO2. Yes, 0.7 into PaCO2 plus 0.7 into bicarb minus 24 plus 40 plus or minus 2. Sir.
Basically, you'll be calculating the change of 0.7 times the change in bicarb. Add it to PCO2, normal PCO2.
Yes.
That's what you're going to do it.
Yes.
So
Yes.
whether it's compensated or not, this patient.
So 1 minute.
It's compensated.
It's a compensated, sir.
Yes, perfect. Next, how will you approach? Okay, depends on the urinary chloride. Okay, if urinary chloride
Then
is
urinary chloride, sir. If it is less than 20, so then we'll decide whether it is chloride responsive, sir. If it is more than 20, then it is chloride resistance.
no, it is not 20. It's less than 25 and chloride is more than 40. Okay. Okay, next.
Okay, sir.
So it's a chloride response, alkalosis. The condition
Chloride responsive.
GI losses are with diuretics. Generally, this is a cause for chloride response.
Diuretics. I mean.
Yes. So if in your ICU you feel that it's a metabolic alkalosis secondary to diuretics, we have a confusion whether it's a metabolic syndrome, something related to that, or it's due to obvious use of diuretics, you can just do a urinary chloride. That will give us an idea whether it's a chloride, it's due to diuretic use or something else is there. So you want to make use of this, make use of this protocol to identify what is the cause of metabolic alkalosis. So next patient is 38-year-old lady, BP of 160 by 108, hypertensive. This is the labs of this patient. ABG, pH of 7.57, PO2 of 95, PCO2 of 44, bicarb 38, sodium 144, potassium 3, chloride 101, urinary chloride 42, plasma renin is normal, aldosterone is elevated.
Well, somebody else could take this
Yes,
up if you don't.
Somebody else should.
I think Pradeep is keen, but I should give somebody else a chance.
Hello, sir.
Yeah, go ahead.
Krishna. So pH is 7.57. So it's alkalemia.
Yes.
Hello.
Yeah.
Yeah, please.
So it's alkalemia. Then bicarb is 38. So it's metabolic alkalosis. Then for compensation,
yes, go ahead.
like 0.7 into bicarb plus 20, it will be 46. So it's compensated.
Yes, very good.
So compensated metabolic alkalosis. Then we have to see for the urine chloride levels.
Yes.
It's 42. So it's chloride resistant.
Yes.
Metabolic alkalosis.
Okay. Do you know any other way we can further approach this patient?
If the patient has high
a patient has high blood pressure. Okay. Any patient, if you get alkalosis in the ICU, you can further work up depending on the urinary chloride. If they have a high blood pressure, it is due to mineralocorticoid excess. They're like aldosteronism, hyperaldosteronism. If patient has a normal BP, with some electrolyte disturbances, you should suspect Gittel-Mann-Bartter syndrome, this kind of clinical picture. So this is how we'll approach this case. Okay. If anybody else can volunteer for this case, or Krishna, will you go ahead and do it? You are called to the emergency department to review the ABG of an obese patient, 55-year-old hypertensive male, who complains of daytime somnolence. He has the following ABG: FiO2 of 0.21, pH of 7.33, PO2 of 40, PCO2 of 64, bicarb of 33. Standard base excess is 5.4. How will you approach this ABG? Interpret.
Anybody else can think it through as well. So message or comment.
See, I'm covering most of the ABGs which can be asked in the exam by one example. Okay, this can come in the exam. This from the respiratory component, this is one of the most common examples you'll get in the exam. Anybody?
Hello, sir.
Yes, please go ahead, Pradeep.
Sir, mainly this, it's a respiratory acidosis. Primary problem is the respiratory acidosis. pH is 7.3. It's acidemia, and PCO2 is 60%. So it's mainly respiratory acidosis.
Yes. How will you calculate compensation in case of respiratory acidosis?
Mainly whether it is acute or chronic. So based upon acute, so for every 10 mmHg change in PCO2 levels, so one bicarb is increased. So it's if it is an acute, and if it is chronic, for every 10 millimeters of mercury carbon dioxide increases. So there is an
do you think it's
4 increase in carb. Sir?
Do you think it's acute or chronic?
So it looks like chronic, sir.
Why do you think it's
because
chronic?
he's an obese patient?
Yes.
Hypertensive, daytime somnolence. OSA, sir, it looks like OSA. Chronic.
Okay, fine. That's
chronic
okay.
respiratory failures.
Compensation, you said. Anyway, it's a compensated one. You can calculate that
Yes,
one.
sir.
So how will you calculate
Yes,
AA
sir.
gradient?
Yes. The AA gradient mainly, it's a alveolar minus arterial gradient. Sir. The formula is it's atmospheric pressure minus saturated water vapor into FiO2 minus PaCO2 by respiratory quotient minus PaO2, sir.
Yes.
So based upon the water vapor pressure is 47 mmHg. If you calculate 150 minus 1.2 into PaCO2, sir. So that's a simple formula.
Yes, very good.
Yes, so AA gradient is
A gradient is 30 in this patient. Do you think it's normal or elevated?
it is increased, sir. It will elevated, sir.
Yes. Okay, fine. That's good. I think that's all from my side in this ABG perspective. I think most of you must be knowing these compensation formulas. If you don't know, please take a screenshot of this one. Okay.
If you don't mind, just we go through the first slide where you had the steps given, Rajvardhan. We'll just show that once, the way how you read the ABG.
Yes.
So just for all practical purposes, those who joined late, the steps of ABG, make sure that it is a valid ABG. So if it is a station, you could quickly do the numbers. Like I said, the compensation numbers, you do it before you open, like, before start answering. If the examiner is saying that, you don't have to calculate roughly, is it compensated or not, you should tell me. Then you can always do the mental map and do it. So that's all. And like Rajvardhan was saying, decisions about using the delta gap for acidosis or a complex acid-base disorders, and rarely A gap measurement, which sometimes they may ask. So these are quite important steps. As long as we logically approach the ABG station, like Rajvardhan had just gone through, whatever may be the example, so you will generally get through. So most of you should, like Pradeep was saying, reasonably crisp and clear, like most of the messages I'm seeing on the group. So you'll all be okay. So just to make sure that you approach it in a systematic way. Thank you, Rajvardhan. So I think we'll let Carol take over for the ventilator graphics.
Are my slides visible, sir?
Yes, Carol. So go through the full screen.
Sorry. Good evening, everyone. And thank you, Dr. Justin, for giving me an opportunity to be a part of this program. And also thanks to Dr. Rajvardhan. That was a great discussion about the ABGs. And I want to keep the energy going. I want more answers from all of you all and more participation. It's okay if you make mistakes. This is not the final exam after all. The idea is to learn and to, try to attempt at least, right? So when they show you a ventilator graphic, it could be either to identify the modes or to identify some abnormality. All right. So most of you would have learned modes by probably pattern recognition, right? So you'll be like, okay, if it's square shaped, it's probably volume control, but that's not the idea. What you should observe is what are your control variables. Is it a pressure controller or a volume controller? Volume or flow controller is nothing but the same. Okay, so if it's a pressure controller, you'll see a constant pressure throughout inspiration. And if it's a flow controller, you're going to see a constant flow or a constant, it'll never be a constant volume. You'll see a constant flow. Okay, remember volume is nothing but the inspiratory flow into the inspiratory time. All right, it's also important to have a brief idea about the phase variables. Anyone knows what these phase variables are? What is the trigger? What is the limit? What is the cycle? Any clue? Anyone wants to volunteer a guess before I start showing you graphics? What are the common triggers you all know of?
Time trigger.
Very good, time trigger. And if it's patient triggered, what are the common triggers we have?
Pressure and flow triggers.
Very good. So if it's patient triggered breath, it will be either a negative deflection, that's your pressure triggered, or a flow triggered, depending on what you set. Okay. And as an operator, you will also set something called as a trigger sensitivity. What is the limit variable commonly? So it
25%.
depends on the modes. Sorry, can I not hear you? Could you please speak up, whoever was answering? Just venture a guess, it's all right. So when I say the term limit variable, a limit variable is a variable that doesn't cross a particular limit throughout inspiration. So typically in volume controlled, it's usually flow. If it's pressure controlled, it's usually pressure. What you set, the pressure, that's what it will maintain. It will go from 0 to that set pressure and sustain it throughout inspiration. Any idea what is cycle variable? So this is important because without knowing these basics, it's very difficult to identify the type of modes. So what is a cycle variable?
The variable that ensures cycling between inhalation and exhalation.
Inspiration and expiration. So very good. It's the variable that changes inspiration or moves the patient from the inspiratory phase to exhalation. Yeah. And the baseline variable most common is a peep. If you keep a peep of 0, it is Z. If you keep a peep of 5, so that becomes your baseline variable. Okay, so we'll just go through a few slides, and I want you to all answer first what is a control variable, whether it's a pressure controller, volume controller, and to identify the various phase variables. Yeah. So this is the first graphic. So just to so these are called as, so commonly you will be given a graph which may have 3 of the scalars: your pressure time scalar, volume scalar, volume time scalar, and flow time scalar. Okay, and loop is basically measuring 2 variables against each other. So it could be flow volume or pressure volume. So what you're seeing right now are scalars. So from the scalars, I'd like someone to basically identify first what's the control variable or what kind of mode it is basically. Anybody?
I'm volume controlled.
It's a volume.
Good. Why are you all saying it's a volume controlled mode?
Quiet flow pattern.
I'm sorry?
Quiet flow pattern.
Square flow pattern. So
Flow is constant.
better than saying square flow, a better answer would be that the flow is
Volume
remaining
is equal.
constant. Yeah. So you see the flow at the start of inspiration. I'm sorry. Am I audible to everyone? Okay. So what you're seeing over here is that basically the flow is going from 0 to whatever the inspiratory flow is set. It's maintained constant throughout inspiration. Yeah. And what is changing here is the pressures. So the pressures are basically changing depending on the compliance or the resistance of the lungs. So this is a volume controlled. So what kind of trigger is it? What is the trigger variable here?
Time triggered.
Excellent. It's time triggered because you're not seeing any patient spontaneous efforts. And so if you see the pressure time, you're not seeing any spontaneous efforts by the patient or trigger by the patient. So after a fixed time, the flow is beginning, okay? And the volume is delivered. So it's time triggered. Limit, what is the limit variable?
Flow limit.
Flow limited.
Very good, flow limited. And what is the cycling variable here?
Time cycle.
Time.
So I hope there's no doubts in this. So you're able to see that the patient is not generating any spontaneous trigger of their own. And after a given point of time, the inspiratory flow is cut off and then it goes into the expiratory flow. So like most of you said, this is a volume controlled mode. So volume controlled, flow controlled is the same, okay? So don't break your heads on that. So what you're seeing over here, it is time triggered. You're not able to appreciate any pressure trigger or flow trigger set. It is flow limited because the flow remains constant in a volume cycle ventilation. And it's a time cycled. I wouldn't call it volume. Volume cycled is also technically correct, but this is more correctly as a time cycled form of ventilation. Okay. Okay. Somebody else now. Can you venture a guess to what this is now? What kind of mode is it basically?
Pressure is constant. Pressure control.
Very good. So your control
pressure
variable
control
is
mode.
pressure control. Yes. Now can we go through the phase variables? What do you think is the trigger here?
Time trigger.
Time trigger. Okay.
Time trigger, ma'am.
Okay, great. Then
Pressure limited.
limit, pressure limited,
Pressure limit
and the
and
cycling
time cycle, ma'am.
time cycle. So anyone has any doubts here, you all can stop me. So what you're seeing over here is that the pressure is remaining constant throughout inspiration. Okay. And the flow is very typical of pressure controller is the decelerating flow. Okay. So you'll always see a decelerating flow. This can be seen in pressure support as well as pressure control. But this decelerating flow is typical of your pressure controller modes. Okay.
And what is the negative flow?
I'm sorry, I cannot hear you.
Ma'am, what is the negative flow?
Expiratory.
Decelerating flow. So what you're seeing is over here at the beginning of inspiration, the pressure rises, you will see a subsequent increase in the flow. Okay, there's a sudden increase in the flow of gas into the patient's lung, and this gradually decelerates over a period of time till it is expiration. And then this waveform, your expiratory waveform, both in pressure control as well as volume control, because exhalation or expiration is a passive process. So this is totally dependent on the resistance and compliance or the time constant of the patient. Okay. So we'll show you a little bit more examples for this expiratory flow as well. Whereas if you remember in the volume control, this was one of you said square pattern, but the better term will be it's constant. The flow is remaining constant as compared to here in the pressure controller mode. Yeah, so this is what most of you all said. It's the pressure controller, time triggered, pressure limited, and a time cycled ventilation. Yeah. So this peak, what you set over here, what is this point or this level?
Plateau
This
pressure.
is nothing but it's the peak inspiratory pressure. It's what you set, the PEEP plus the pressure controller or the pressure that you set. Okay, say you set a pressure of 5 and over and above that pressure, inspiratory pressure of 15. So this will be corresponding to 20 centimeters of water. Okay, over here you will see that there is no PEEP set over here. It's starting directly from the baseline. So this is a ZEEP or a zero end expiratory pressure. If there was PEEP, then you would have seen it starting above from the baseline. Yeah. Any doubts here? Should we move to the next slide? Okay. So first, what is the mode of the ventilation? Yeah, by now you should be familiar. So faster answers here.
Volume control.
Assist control mode.
What is the
Volume.
mode? What is the controller? Volume control, assist control. Fair enough. Great. Then now what is the trigger here? What are you able to appreciate?
Patient triggered,
Patient
ma'am.
trigger.
Patient trigger. But what is the type of trigger?
Pressure trigger.
Pressure trigger. Excellent. Okay. So pressure trigger, when patient triggers a breath, you will see a small negative because patient is trying to inspire. So there's a negative intrathoracic pressure, which will be seen as a deflection in the negative direction. If it was set to flow, so remember this trigger can be set by you as the controller. You can tell the ventilator whether you want it to be a pressure trigger or a flow trigger. So pressure is usually negative or minus, usually -1, -2. And flow is usually positive. Okay, so if the ventilator, if you set flow trigger, the ventilator detects a change in the inspiratory and expiratory flows, depending on what you've set as a trigger, it will know that it is time to trigger the next breath, or the patient is trying to trigger the breath. Okay, so this is patient triggered. Very good. So this is a pressure trigger. What about this thing, limit variable here? Limit variable?
Flow limited.
Flow.
Yes, exactly. It is a flow limited and pressure triggered breath, right? And it's time cycled over here. All right. So coming to this, now what are you able to see over here? So what's the predominant thing that you're seeing over here? What kind of control variable you're seeing? Forget the part that's in blue. What else are you seeing?
Volume control.
Constant.
It's flow
Volume
control.
control.
Volume control. Excellent. Yes. Are you able to appreciate that there is a trigger?
Yes. Patient.
Pressure trigger.
You're able to see
Trigger.
that there is a what trigger? Pressure trigger is seen. Yes. Okay. So what is
Patient.
happening over here in the center
Yes,
in
ma'am.
blue?
Spontaneous breathing.
Spontaneous.
Yes. So what you're seeing over here is a patient-triggered ventilator breath. It's triggered by the patient, but then it's delivered by the ventilator. This is immediately followed by a spontaneous breath by the patient themselves. They're triggering. And if you see, there's a change in the flow over here, right? You're seeing a constant pressure. There's a slightly decelerating flow. Okay. So this part is volume control, but this is a pressure-supported breath. Able to appreciate that?
Yes.
There's a decelerating flow here, the pressure is remaining constant. So this is nothing but it's a SIMB, that's your volume targeted, but there is also a pressure support that has been applied over here, okay? So this is an SIMB, this is a typical example of your synchronized intermittent mandatory ventilation plus a pressure support. So when I say a controlled breath or a controlled mode, a controlled breath is basically triggered and cycled by the ventilator. If it's a spontaneous breath, it is triggered and cycled by the patient. Whereas if it's a combination of both, it could be a continuous or a spontaneous breath, sorry, a mandatory plus a spontaneous breath. This is usually an intermittent mandatory ventilation. So what you're seeing over here, okay? So there's ventilator breaths along with spontaneous breaths by the patients. So this is your typical example of your SIMV plus pressure support. Okay, so this is volume time scalar. Okay, so I want you all to just look at it and one of you to tell me what is the abnormality you're seeing over here.
Air leak.
Ma'am, it's
First, tell me what
volume
you're
time
able to
waveform.
see. Okay, it's a volume time scalar. That will be correct. Yes.
It's not touching
Actually,
the patient.
expiratory wave.
Yes.
Yes,
So
ma'am. So
it's not
expiratory
touching
wave
where it
not able to
expiration or
touch the baseline,
inspiration.
ma'am.
Yes, it's not touching the baseline in
Expiration.
the expiratory phase. Okay, so one possible cause, one of you all have already
Yes,
answered, is a
Leak.
leak.
Air leak.
Yes, very good. So this is correct. This is a classical example of air leak. If you see this, what else would you want to see on the ventilator to confirm whether there's an air leak or not? Is there something else you want to look at the ventilator screen?
Flow volume loop. I wanted
Very
to see.
good. You want to see the flow volume loop. Very good. Okay. Is there something else you want to see on the ventilator to confirm there's actually a leak happening or not?
Expiratory volume.
Expiratory
Difference
volume.
between
The volume that you have given to the patient and the expiratory volume. Usually the difference in that would amount to the leak. Okay. So you can make out the amount of leak from here, or you can also look at the difference in the inspired and expired tidal volumes that the patient is generating. Third, like one of you have said, correct, you can also look at the flow volume. So there also it does not touch, it does not reach zero at the end of expiration. I have an example for that. I'll show that to you later. Yeah. This is air leak. Okay, so what is happening here? This is an intubated patient and you are experiencing some difficulty to ventilate the patient. So upfront, what are you seeing?
hyperinflation auto-peep.
It's a flow time scalar, ma'am, where in the
Very
expiratory
good. One
flow
person
limit
at a
is
time,
not.
please. I'm not able to see who's answering. Yes, tell me, sir, you were answering something. The flow time scalar.
It's a, yes, ma'am. It's a flow
Dynamic
time scalar
hyperinflation.
where the expiratory limb is not touching the baseline. Before that, the inspiratory phase has been begun, ma'am.
Yes. So
So
what
it
do you
is
call
nothing but auto-peep, ma'am.
this?
Auto-peep it is.
Auto-peep, okay.
Yes.
Auto-peep or expiratory flow limitation. So if you see over here that the expiratory flow, instead of touching the baseline, before just short of touching the baseline, inspiration has already started. Somebody mentioned hyperinflation. Yes. So remember, auto-peep and hyperinflation, they are linked, but they're not exactly the same. Okay. So as this process increases continuously, there's breath stacking, and that leads to a dynamic hyperinflation. Yeah. So now how do you confirm whether this patient is having an auto-peep or not? How do you know? What is the maneuver you want to follow this up with?
I'll do end expiratory hold.
So I'm hearing expiratory pause, end expiratory pause, or an end expiratory hold. Okay. And what do you expect to see at the end of that? So why are you giving this end expiratory pause?
To measure total
Only to
peep.
see the intrinsic peep, ma'am. To find out intrinsic peep.
Yes, you're basically equilibrating the flow over a period of time, and that will give you the total peep. That is it going to give you just the intrinsic peep, or you have to calculate it? What does it give you?
Total peep. It will give
It gives you
total
the
peep.
total peep. Yeah. So say the set peep is 5 and the total peep is 11. So your intrinsic peep is
6, ma'am.
6. So sir, can somebody tell me what are the problems of a patient having intrinsic peep?
It's difficult to deliver volume.
Difficult to deliver volume. Why so? There is volume getting delivered. No, this patient will have volume delivery.
The patient, it will be difficult to trigger the ventilator.
It causes a difficulty in
Patient
triggering.
will
Yes.
find it difficult to
And
breathe.
the
Yes. So
work
there is
of
an
breathing will
work of
increase.
breathing.
Work of
Correct.
breathing.
So as in the breath stacking keeps on increasing, then definitely there is an increase difficulty in trigger there's an increased work of breathing, and thus the patient has to take more effort to trigger the ventilator. Correct. So can somebody tell me the common causes of expiratory? Somebody else now. Some common causes of this expiratory flow limitation, and how do you want to troubleshoot? Anybody?
There could be a kink in the tube or secretions.
Secretions or a kink? Okay, not really.
Bronchospasm.
Who's having
Spasm. Okay, fine. I'll accept that.
known COPD patient?
Yes, commonly seen in non-COPD. Okay, why so? Why does this happen in COPD patients?
Because of the dynamic hyperinflation, narrowing of the airways. So increase in resistance for the expiration to happen.
Okay, so what happens is basically there's an increased resistance. So I agree with that. There's an increased resistance. So any bronchospasm or a patient with acute exacerbations of COPD, because of the increased resistance, the time constant is prolonged. Time constant is nothing but the product of resistance into compliance. So this expiratory flow, this waveform is determined by the time constant. So the patient requires more time for emptying the alveoli. Okay, so if you have not set an appropriate expiratory time or there's a very severe bronchospasm, then this will give rise to your expiratory flow limitation. This can also be seen in a normal patient if you have kept a high respiratory rate or you've kept a shortened time for expiration. These are other common things that you will have to troubleshoot. Okay, so if it's a patient who has a bronchospasm or COPD, obviously you have to tackle that. You have to do the medical management. If it's because of a high respiratory rate, you probably have to lower the respiratory rate. Or if it's because of shortened expiratory time, you've not kept enough time for exhalation, then you will have to come down on this. Okay, so where else can I be able to appreciate this auto-peep? One is over here in the flow time scaler. Anywhere else in the ventilator?
In flow volume loop, we can identify, ma'am.
Yes, in the flow volume loops also you will be able to identify this auto-peep. Okay, and in certain ventilators like the servo, you get this end expiratory flow. Usually it should be 0 because at the end of expiration should be 0. So if it's anything more than 0, like 1, 2, 3, 4, it tells you that there is some amount of gas trapping at the end of expiration. Yeah, it's called VEE in some ventilators, end expiratory flows. Okay, so this we've already discussed. What is the maneuver used to calculate auto-peep? Okay, so this is how it will look. Once you give an expiratory hold, you're equating the flow, and this value that you get is your total peep. So if you subtract it from the peep that you have set, that difference will give you your intrinsic peep. Okay, fine. So this is the next question. Can somebody tell me what are you seeing over here? This is an easy one.
Secretions.
Secretions.
It's secretions
Inability
in
to
the
trigger
circuit.
the ventilator.
Inability to trigger the ventilation. Yes, so secretions can cause something called as auto-triggering, ma'am. Rather than inability to trigger, it will auto-trigger the ventilator. So even though the patient is not triggering, it will. But the correct answer for your level, for especially with the IDCCM examinees, I think it would be great if you just say there are secretions or water condensates in your ventilator tubings. This is how it will look. Yeah. Okay, so look at the first waveform on the left and look at the second waveform on the right. And what is the problem in the first waveform? What is the intervention that causes the waveform to change? So what is the problem in the first waveform?
Increased expiratory time.
In the
What
first
scalar is this? Before I ask this, what scalar is this? There is a V on top.
Volume.
What scalar is this?
Volume time scalar. Volume and time.
Flow time.
Flow time.
Very good, very good. So the people who are saying flow is correct. So V with the dot is not volume. This is how it's represented. It's represented on the ventilator. V with the dot really means flow. All right. So don't get confused with the V over there. Okay. So this is a flow time scalar, and this is a flow control. You can see, right? The flow is remaining constant. And remember that expiration is always passive. So you cannot have a constant flow there. Okay. So what is happening in the first part of the scalar, the left half?
Peak
Expiratory flow limitation is there.
Expiratory flow limitation is there.
Peak expiratory flow rate is low, ma'am, and also
Yes.
time for expiration is increased.
Very good. Okay, so there is definitely this part, this straight line below the baseline, that is what gives you your peak expiratory flow rate. What's the maximum expiratory flow rate? Okay. So in a patient who's got, so which condition will this peak expiratory flow rate be reduced? And it takes a longer time to reach the baseline. So the person who said that there's some airflow limitation here, it is actually reaching the baseline. So you've probably set adequate time for the expiration. Okay. So I do agree with the people who said that there is a decreased PEFR and it's taking a longer time for the flow to touch the baseline. So which condition will you see this? Common condition?
Obstructive airway
Any increased resistance. So any increased resistance, there'll be a shortening of this peak expiratory flow rate and the time constant is prolonged, right? So the time taken for this. So this expiratory flow waveframe, it depends on your R and C. So the R is increased, that is your resistance is increased. So basically it will take a longer time for it to reach the baseline. So can you tell me what intervention has happened on the right and things have improved or remain same? Or worsened? What has happened?
Bronchodilator has been given me.
Very good. Okay.
So peak expiratory flow rate is increased and also time to expiratory is decreased.
Yes, correct. So time constant, like I said, is nothing but R into C. By reducing the resistance by using a bronchodilator, now you're seeing that the flow waveform is reaching the expiratory flow is reaching the baseline faster. And by administration of your bronchodilator, there is an increased or an improvement in your peak expiratory flow rate. So this can be measured sometimes with spirometers also in patients who are not intubated. All right, so this is exactly what you all said. So the peak flow over here was shortened and there was a longer time for exhalation because of the increased resistance. After a bronchodilator, you will see improvement in the PEFR and a shorter time because the resistance is now lesser and the time constant is now lesser. Okay, so sorry. So what is 1, 2, A and B? So 4 different people can answer. What is, this is obviously a pressure time scalar. It's indicated from the picture itself. So can somebody tell me what kind of, what mode is this before we start?
Volume control.
Very good. Why do you say so? It's volume controlled?
Pressure is varying.
Yes, very good. So you've understood the concept. Okay, so what is 1, 2? What pressure is 1? What pressure is 2?
One is peak inspiratory pressure. Peak inspiratory pressure.
Which is peak pressure? Start, we'll go in sequence. What is 1?
Peak inspiratory pressure.
Inspiratory pressure.
Peak inspiratory pressure. What is 2?
Plateau pressure.
Plateau pressure.
Plateau pressure. Very good. What is A?
Resistive work.
pressure.
Resistive work. It is.
Yes, the resistive trans-airway pressure or the resistive load. And what is B?
Elastic work. It is. Elastic work.
Elastic work. Okay. So just to recap, if you remember your equation of motion. Okay. So equation of motion is basically the pressure that is required to overcome the resistive load, that is flow into resistance, plus the elastic load, that is elastance into volume. Okay. So this initial rise that you see in the pressure, okay, this part is what is required to overcome the resistance by the airways. That could include your endotracheal tube, trachea, bronchi, so on and so forth. And what you're seeing over here in the B portion is basically determined by your compliance or the elastance of the lungs. Okay. So what is the importance of this? Why is it important for you to know the peak inspiratory pressure and the plateau pressures? How is it helpful for you?
To differentiate the cause for the rise in pressure.
Okay, just to, I'll come to this in the next slide. We'll discuss this a little bit more in detail. So you all were right. The peak inspiratory pressure is the maximum pressure. Okay. The plateau pressures. Okay. So can somebody tell me how do you get the plateau pressures? What is the maneuver you will do to get this plateau pressure?
Inspiratory hold for 6 seconds.
Okay, at least 3 to 5 seconds, you will give an inspiratory hold. Okay, and what does this do by giving the inspiratory hold?
We are taking away the resistance and we are measuring the component.
We are equalizing the pressure.
You're equalizing the flow from the opening, airway opening to the all the way to the alveoli. Okay, so that will basically give you the pressure at the level of your alveoli or the pressure of your lungs. So that is your plateau pressure. So why this is important is that, okay, so this is important. The need to know this peak inspiratory pressure and plateau pressure, it's because it will tell you if there's a problem with resistance or with compliance. So look at this picture and tell me if there is a change in resistance, that is this portion. Yeah, if this portion is increased. So change in resistance happens. So what is going to happen to your peak inspiratory pressure? Is it going to increase, decrease, or stay same?
It will go high.
Increases.
It will increase, ma'am.
So if it's a resistance problem purely, only this A portion is going to increase. So the height increases, so your peak inspiratory pressure will go up. What about the plateau pressure if it's purely a resistance problem?
Normal.
Same, normal.
Crystal normal.
Yes. So that is the importance that you should understand and know. Yeah, you should not mug this up. You should understand why it's happening. So if there's a change in resistance, only the height of the A portion will increase. That's only increasing your peak inspiratory pressure. Whereas, like I told you, by giving an inspiratory hold, you're basically getting an idea of the pressures at the level of the alveoli of the lung. So if there's a change in elastance or compliance, so what is going to happen to your plateau pressures?
Go
Are they going to stay same, reduce, increase? It will go up. So if this part of the curve is increased, so you're going to get see an increase both in your peak inspiratory pressure as well as your plateau pressure. Okay. So this is the important part that I want you to identify. So if can you make out the difference here? So what is happening over here in graph A?
Peak inspiratory pressure is high.
Only the peak
inspiratory
inspiratory
pressure is
Resistance
plateau is not changed. So this is because this portion or the resistive load had increased. Okay. So now give me some common examples where the resistance will increase, causing a peak inspiratory pressure to go up.
Kinking of tube, bronchospasm.
Okay.
Bronchospasm.
So it's mainly mission
ask-
related, operators related, and patient related, ma'am.
Beautiful. So go as systematic as you can so that the examiners will understand that you'll, when you'll approach the patient also, you'll go either you'll go from machine end to patient end or patient end to machine end. So tell me some causes, please. Yeah, somebody was answering, right? Patient related, machine related. Go on, give me some causes.
It might be operator related, ma'am. If there is any kinking, so ET tube clink or any clogging, either it may be mucus flux.
Okay.
And patient related, it is bronchospasm.
Okay. Okay, correct. So yeah, so bronchospasm, or there's any kink in the tubes, a blocked HME filter, a very common cause, okay, or a blocked tube by mucus plugs or secretions. So these are common causes where you will have increased peak inspiratory pressure because of increased resistance. What about slide part B, where you're seeing both peak inspiratory pressure and plateau pressures? What is the problem? Is it a resistance problem or a compliance problem again?
Compliance.
Compliance problem, yes.
It's a compliance.
Very good. So can you give me some common causes as to why this could be happening?
Pneumothorax, dynamic hyperinflation.
ARDS.
Pulmonary edema.
ARDS, pneumonia,
ARDS, ma'am, alveolar problem.
collapses. Yes, very good. So primarily problems in the lungs. Okay, so if you imagine the lung as a straw and the balloon, anything to do with the straw. The straw is nothing but your trachea and your airways, endotracheal tube. That is what's going to cause an increase in the resistance. Anything to do in the balloon portion, that's basically at the level of your lungs or alveoli. So that is going to cause a change in your elastance or your compliance. Okay. So anything, it could be ARDS, pneumothorax, what are the examples that you have said? Perfect. All right. So this is a very important concept. I don't want you all to mug it. You all should remember this. Okay. Why the peak inspiratory pressure goes up in resistance and why there's a change in both peak inspiratory as well as plateau pressures and decrease compliance or increase elastance. Okay, so can somebody tell me what are these loops before we identify the modes? First, can you tell me what is this loop? This loop on the, what is the first loop? Pressure volume loop. Okay, so pressure is on your x-axis and volume is on your y-axis. Okay, so a loop is basically, it will scale one variable against another, not against time, one variable against another. So commonly you have your pressure volume loops as well as your flow volume loops. Yeah. So looking at the first one, okay, so this one on the left, can you tell me, just looking by the pressure and volume and what's happening, what kind of mode it is? So if you remember the first slide, if you all understood that concept, you all will be able to answer this.
Pressure controlled.
The first one is pressure controlled. Why would you say that? Why do you say that? You are correct. Why do you say that?
Pressure is inspiratory pressure is constant.
Pressure.
So can one person answer, please?
Inspiratory pressure is constant.
Okay, so you see that the pressure is rising and it's remaining constant. So this is inspiration, right? It starts from 0, goes up, and then it's maintained constant and then again drops back down. But what is changing is you're seeing a decelerated flow. What are you seeing on the right side? What is happening in the flow, in the inspiratory part? So what is above the baseline is inspiration. So what's happening? It's constant, yeah? So this is a flow controlled mode, okay? So now you have your PV loops and your flow volume loops. So can somebody just summarize what is the information that one gets from PV loop? So why is it important for me to look at the PV loop?
Compliance.
So one is compliance will come to know.
Okay, excellent.
Resistance.
Yes. Okay.
And any leaks.
Leaks. So more of compliance changes you will get to appreciate. Okay. Then leaks. Yes.
To set the PEEP.
Any over
for PEEP titration. Okay.
Any over distension.
Beautiful. Yes. Sometimes you'll be able to also pick up any asynchronies like flow asynchronies. You see that scooping pattern or scalloping pattern that's there in the pressure waveform, especially during the inspiration flow. Okay. So yes, this is all the information that you get from PV loops. So commonly we use this for changes in compliance. Okay. So just to give you some more examples. Okay. So first, this is also a PV loop itself. Can somebody tell me what is this value of A denote?
FRC.
The lower inflection point, man.
A is the point that is touching the baseline. This point, exactly this point.
Peep.
Exactly, beautiful. So that's the peep that you have set. If you had not kept a peep, the volume, the PV loop would have started from here. So because you've set, say, a peep of 5 or 10, this is where your PV loop starts. Okay, so the pressure starts increasing over and above the baseline variable, which is the peep that you have set. Great. And so what is the pathology you're seeing at point B?
Beaking.
Beaking, ma'am. Alveolar over distension.
Super. So you're seeing an alveolar over distension. So what is the problem that's likely happening? So that's
High tidal volume.
Yeah, you've set a high tidal volume. Sorry. You've set a high tidal volume. So that's basically causing an increase in the peak inspiratory pressure. And the compliance curve is also shifting to the right, which tells you that the compliance is reducing. And there is a high peak inspiratory pressure, which could then give rise to barotrauma. So what would you like to do in this patient to reduce this beaking?
Reduce the tidal
volume.
Yes, one thing that you could
Reducing
do
the tidal volume.
Reducing the tidal volume or identify the condition that's causing the change in compliance. Okay. So this is what mode. Is the pressure changing or the volume is changing?
Pressure is changing.
Pressure is changing.
Volume
So
control.
what mode is this?
It's
Volume
the
control.
Very good. It's a volume control mode. Okay. So this is basically the changes in compliance that you're seeing. In blue, the compliance is good. This is the normal or the reference PV loop, and the resistance or the compliance which is worsening, which is giving rise to that increased PIP. What would happen? Now imagine this was a pressure controller. What would happen if the compliance reduced to the PV loop?
The volume will drop down.
volume will drop, ma'am.
Okay. So the volume because the pressure will not change. So the set pressure would remain the same, but you will see that the volume curve or the PV loop will move towards lower and to the right. Okay. So the volume will drop for the same pressure. Remember, compliance is nothing but change in volume per change in pressure. Okay. So if you remember that concept, you will remember this. Okay. So this is something we already discussed actually.
Leak.
So what loop is this first before we
Flow volume
loop.
There's no doubt in this, right? So this is volume. This is 0. So this is inspiration above, and this is expiration over here. The lower half is expiration. Yeah. So this point, what is this point over here?
The total lung capacity. Vital
No.
capacity. Vital capacity.
Functional decibel capacity.
So these are not spirometry loops, no? Spirometry loops are different from here. So this is basically going to give you the tidal volume that you have set. So if you set a tidal volume of 500, that's what you're going to see over here. Okay, and at the end of expiration, you will expect it to reach 0. But is it reaching 0 over here?
No.
No.
No, ma'am.
Okay, so just because I think there is some confusion here. So this is nothing but, see, this is a flow volume loop. At the beginning of inspiration, the flow is increasing. It's remaining constant. So this is a flow controlled or a volume controlled. And it will go to the tidal volume that you have set, which is 500. At the end of expiration, the flow drops and the volume has to come back to 0. Yes, but it is not coming to 0. It is stopping short of 0. So what is the problem here?
Leak.
There is a
Leak.
Yes, there is a leak. There's a leak of almost 150 ml that you're seeing over here. All of you can appreciate that, right?
Yes.
Any doubts? So the end of expiration, you will expect this loop to end at 0. That's what the reference loop is over here, but it is stopping short of it because there's around 100 or 150 ml of leak. So this is along the scala, you'll be able to see this is 100, this is 200, so on and so forth. What if it ended over here on the y-axis?
Auto-peep.
Auto-peep
Yes,
generation.
that is basically your air trapping, expiratory flow limitation. So this is something that we had discussed earlier. I'm just showing it to here. Okay, so this is over here. The expiratory part of the loop does not return to the starting point, which indicates a leak also. Okay, so what is happening here? What kind of scalar this is? This is a
Pressure.
yes.
The pressure time scalar,
This is a pressure time scalar.
volume control mode.
Yes, beautiful. What is happening?
Flow starvation. Flow is
Yes, this is a typical example of your flow starvation. So the patient, the inspiratory flow that you've set does not match the demand of the patient. So you will probably have to increase your inspiratory time or the inspiratory flow or tidal volume. Okay, so this is a little tricky, but it may or may not be asked for you all. Okay, so I'm just moving to 2 slides on some asynchronies, common patient ventilator asynchronies. So this is your pressure time scale. I'll make it easy. The first one is a pressure time scalar. The second one is a flow time scalar. So this is a pressure controller. You can see the constant pressure, decelerating flow. And this is basically your esophageal pressure that is measured in this patient. Okay, so each time you're seeing these red arrows, it's the patient, triggering a breath. Okay, so what are you seeing over here in the flow time scalar? This is the expiratory flow and you're seeing one upward blip. What do you think is happening over here?
It's a trigger, ma'am.
Yes, the patient is trying to trigger, but is it? Can you see a waveform over here on top corresponding to it?
Ventilator is not supporting them.
Yes, so this is called an ineffective trigger. Okay, so the patient's trigger, he's trying to trigger the breath over here, but the patient is not, the ventilator is not recognizing it. One common cause would be that you have not set an appropriate trigger sensitivity. Another common cause is what we had discussed with the presence of auto-peep. So because of the presence of auto-peep, the increased work of breathing, and this work of breathing, the patient is trying to trigger the breath. It's not sufficient to overcome that work of breathing because of an existing auto-peep or an intrinsic peep. Okay. And lastly, over here, same thing. This is a flow time scalar, pressure time scalar, and this is your diaphragmatic electrical activity. That's basically measured by your NAVA. So this is basically, if the patient is triggering, you will see a blip. So what is happening over here? Is there any trigger over here? So here there's a trigger and there's a breath delivered. What about here? Is there any trigger?
No.
No, ma'am.
No, but there is a breath delivered. So what do you think is possibly happening?
Yes, ma'am.
Loudly. Okay, it's all right. So
SIMV mode. SIMV.
No, this is not an SIMV.
Mandatory breath.
This is the mandatory breath.
Okay, not really, because you're seeing there's a decelerating flow. If it was a mandatory breath, you would have seen a different flow, no, like a flow controlled. So this, what is happening is basically auto-triggering. Okay, so the ventilator is triggering by itself or auto-triggering. Okay, so this is commonly seen in, if you've set a low trigger threshold, if there's a circuit leak. So if there's a leak, the ventilator will think that that leak is the patient trying to trigger presence secretions or water or even cardiac operations. So it's not, this is not a typical diagram. So normally you will see this, like multiple breaths delivered together. Okay, when there is an auto triggering. Okay, so I don't think this may or may not be asked in your IDCCM exams, but this is good to identify at the bedside. Okay, I think I shall end here. Over to Dr. Justin.
Just
thank you all.
Go ahead, Rajvardhan. Yeah, go ahead.
There's one more question was asked in the exam. I'll try to share that screenshot. That's it. One more question was there. If you allow me to share the screen, I'll just show them.
Yeah.
You're able to see the PowerPoint?
Yep.
Yes, this one. This was asked in the IDCCM exams recently. I think most of the people. Can you tell me what is it? What are these two modes?
First one is a controlled pressure controlled.
Yes.
Second one is the pressure support.
Yes, that's it. It's perfect. It was asked in the exam recently, so I thought you people just to be aware. That's it. That's it from my side. Thank you.
So I just want to see if participants have any queries or wanted to see any loops in specific one more time or any other questions that you may have. So it was a comprehensive session. Just I think not just going through the loops, but also understanding them. So, and looks like most of you who are is going for the exam seem to be quite good with them. So I'm confident you guys will ace it this time. And like every time, those who are not going to the exam this time, but probably could use this as a way to study, go to the bedside, and use this knowledge to probably practice a bit, so understand a bit. So the whole idea of this is not just about the exam, but for those who are going to go for the exam in 6 months or 1 year, probably it's as a primer. So I thank Dr. Rajvardhan and Dr. Carol for their time and effort coming to this session. And, thanks, Mahesha, for logging in again. Very supportive for this program, and I guess he's been part of this from the day one, as is Dr. Rajvardhan. So, if there are any further questions, please reach out to all of us or one of us in person or in the Bangalore group. I'll be happy to support and help out any way possible. Somebody's asked for the recordings. Like I said, I posted the Bangalore IDCCM YouTube channel is there. So you can search that, and you should probably be able to see it. A few videos, whichever have been done this week, have been submitted. So today's probably will take 24 hours before it gets uploaded. So so most of the sessions this time around should be on it. So you probably see it. Yeah. If there are no further questions, we could wrap up the session. And I thank Vinay in particular, who has been with us to sort of not only set it up emails and setting these things up for us. Thank you, Vinay, and Hallmark team for help extended. Much appreciated. Yes, all good, all good. So all the best for those who are taking exam of 15. So yeah, somebody's asked for the ABG NEGM article. You could share it in the Bangalore group. Or
Yes, I'll share it in the Bangalore.
Yeah, sure. So most of you will be able to access it without any trouble. Thank you, Rob. Thank you. Thank you.